Diabetic retinopathy. Diabetes is famous for causing macrovascular as well as microvascular complications. One of the complications being diabetic retinopathy. So in all of the diseases, the common point is that the abnormality is in the blood vessel. It's now that abnormality may be a blockage or it may be a leakage, as we had said in basic FFA, everybody. But the abnormality is in the blood vessel. So when we read this group, if we are able to understand the pathogenesis of one disease, we are able to understand the treatment of one of the disease, we will see at last that common concepts apply everywhere. So instead of 5 or 7 diseases, this becomes a one group everybody. Only the presentation slightly differ. There also someone will say the only difference is the name of the disease. Everything else you can catch in common thread and understand and retain for yourself. Yes. So now that we are talking about vascular disease, the first disease that we want to discuss is the main disease, everybody. That is diabetic retinopathy. When we say diabetic retinopathy, there is nothing else to say. I know that I have diabetes, everybody, and that is why I have developed some changes. We're not talking about diabetes here, we are talking about a patient who is diabetic who has developed some retinopathic changes. Yes? So the first thing that I want to ask you is, what are the risk factors? Again, saying clearly risk factors for retinopathy, not for diabetes. In a patient already having diabetes, what is the risk factor for developing retinopathy? The first risk factor is duration of diabetes. I hope it goes without saying that the longer I have had diabetes, the higher will be the risk. Yes or no? Yes. So the duration is directly proportional to risk. If a patient one is there who has had diabetes for 1 year versus a patient who has had diabetes for 10 years, obviously retinopathy will be more likely in the patient with 10 years. This gives us two questions every day. What is the best time for screening of diabetic retinopathy in a patient with type 1 diabetes? What is the best time for screening of diabetic retinopathy in a patient with type 2 diabetes? What are we trying to say here, guys? We are trying to say that we know already that the patient has diabetes, so we know retinopathy may develop. So when should we screen or when should we examine the retina to find out whether the retinopathy has developed disease patient or it has not developed apparently healthy? Yes or no? Screening is differentiation of disease from apparently healthy. So when should we screen in type 1? When should we screen in type 2? In type 1, you are saying after 5 years. I will write after 5 years, no issue. In type 2, you are saying as soon as possible. Okay? Now, why the difference in the answers? Because we know type 2 diabetes mellitus is usually asymptomatic. Everybody, old age, everybody, there are no symptoms. Even though we read polyphagia, polypsia, actually there are no symptoms. This is almost always an accidental and incidental finding. One fine day you go and get your blood sugar checked and you find out it's 200. Oh, we need to start. So we say that type 2 diabetes mellitus is almost always a chronic disease, a silent disease. So we don't know when it started. We only know the date of diagnosis, but we don't know actually when it started because of the chronicity, everybody, because of those symptoms. So we assume that if you're diagnosed with type 2, it may already have been 5 or 10 years, and after that we may have diagnosed. So we say don't wait. Diagnose retinopathy or screen for retinopathy as soon as possible. But type 1 diabetes mellitus is an acute presentation in younger adults. Yes, the pathogenesis and the presentation don't have 5 years in between them. So we say retinopathy changes do not develop usually before 5 years. So wait for 5 years and only after that screen for type 1 diabetic mellitus patient retinopathy. I hope we are clear about this. Yes. The second important risk factor is, all of us know, increased levels of hemoglobin A1C. Glycosylated hemoglobin, if it is under poor control, there are greater chances of diabetic complications like retinopathy, like nephropathy, and everything else. The third important risk factor is pregnancy. Moving on, everybody. Hypertension and hyperlipidemia. Comorbid conditions. Both affect the blood vessels by themselves. Yes. And lastly, diabetic nephropathy. So if you have kidney disease due to diabetes, you're almost always bound to have retinal changes also. So these are the 5 important risk factors. The most important risk factor, I will again repeat, is the duration of diabetes. Now that we know this simple information, everybody, let us understand how does it occur. What is the pathogenesis? Yes. So first of all, let us understand what are the biochemical changes. Okay. So what are the metabolic changes, everybody? Basically, diabetes is a metabolic disease at last. So what are the metabolic changes which are occurring at a cellular level, which are leading to the damage of vessels? So we say biochemical changes can be, number one, increased sorbitol accumulation. Just as we saw in lens, everybody, sorbitol pathway gets activated leading to cataract. There will be protein kinase C activation. There will be accumulation of reactive oxygen intermediates. I'm writing ROIs. Also, there will be accumulation of advanced glycation end products. Without going into the detail of the biochemistry here, everybody, which I hope you have a very strong foundation of, these are the biochemical changes which are occurring, which are metabolic changes, which are leading to anatomical vascular damage. Okay. First of all, we need to learn the biochemical changes. Straight question is asked. Now we come to the important point here: anatomical change. What is occurring in the blood vessels? Yes. So basically, I can say that some blood vessel is getting damaged. Now the question comes: which blood vessel is getting damaged? Artery is getting damaged or capillary is getting damaged? Is it a macrovascular or is it a microvascular complication? So we know it is a microvascular complication. So we know that the problem must be occurring in capillaries. The question that the examiners end up asking you is,
Earliest change.
what is the earliest anatomical pathologic change? The answer, you are saying, sir, hypoxia will occur. But how will hypoxia occur? I am talking about the anatomical change. I am talking about the damage. What is the damage? Is an aneurysm occurring? But if an aneurysm occurring, how is it occurring? So the earliest change, anatomical lesion, we say loss of pericytes. I'm not saying parasite, everybody, please remember, it is not infectious. I'm saying loss of pericytes. Now comes your anatomy, everybody, what is a pericyte? But as we know, a lot of our basics are weak, everybody, so what is a pericyte? Let us understand. Let me ask you, what is the difference between the vessel wall of an artery versus the vessel wall of a capillary? So an artery vessel wall, we say artery is thick, artery is strong. Its endothelium is multi-layered, yes or no? But a capillary is fragile, if I can use such English. Capillary is fragile because the endothelium of capillary is a single cell structure, everybody. Yes? Now, because the epithelium of capillary is a single cell structure, it is fragile and it can keep on breaking. So what occurred? Outside the capillary, assume my finger is my capillary, there was another layer provided to give it protection, everybody. Yes? So that is the layer of pericytes. So what can I say? Pericytes are a layer of protection over my capillaries, which are helping it become strong so that it does not keep on breaking. Okay. Secondly, how does an artery pump blood, everybody? In the artery vessel wall, there are muscular tissues. So this muscle pumps, yes or no? But in capillary vessel wall, there is no muscle tissue. So how does the capillary move the blood forward? These pericytes are contractile cells, so they are contracting, they are pressing my capillary vessel wall and leading to pumping of the blood forward. Yes. So this layer of pericytes has two functions: protective function and, as I said, contractile function. Now, this important layer of pericytes is getting lost.
Hi, Suvir.
The capillaries. Due to that, what is happening, everybody? Due to that, the protective function is getting lost. That means the capillaries are now fragile again, they are prone to damage. When they damage out, everybody, when their endothelium gets broken, there will be leakage of blood from capillaries. When there is leakage, everybody, along with blood, everybody, oxygen leaks out. So there will be hypoxia. Yes or no? Lack of oxygen to the retinal tissue. Hypoxia leads to secretion of, we have read in pathology, very important factor, that is vascular endothelial growth factor, VEGF. And whenever VEGF is secreted, everybody, it leads to formation of new vessels. So there will be neovascularization of retina. And as soon as we see neovascularization, we say this is the hallmark for diabetic retina. Okay. So I hope you understand all the changes are occurring, but the basic problem is, again, I will say, the basic problem is loss of pericytes. Had the pericytes not been lost, all these changes would not have been able to develop. Yes. What are neovessels? Pathology, again, everything pathogenesis. We are discussing pathology, yes. What are neovessels? Are they normal vessels or are they leaky vessels? Yes. We call them leaky vessels, guys. Yes. So because they are leaky vessels, neovessels, as soon as they are formed, they again start leaking. Leaking leads to hypoxia, VEGF, more new vessels. Yes. We call them leaky vessels, guys. Yes. So because they are leaky vessels, pathology, again, everything pathogenesis. We are discussing pathology, yes. What are neovessels? Are they normal vessels or are they leaky vessels? Yes. We call them leaky vessels, guys. Yes. So because they are leaky vessels, new vessels, as soon as they are formed, they again start leaking. Leaking leads to hypoxia, VEGF, more new vessels, more leakage, more hypoxia. So this becomes a vicious cycle. And that is why diabetic retinopathy is self-perpetuating. I hope you understand the basic pathology. If you understand the basic pathology, everybody, without even telling you, everybody, I can ask you to see these two words. and you already know the treatment. You have read the macular disorders just now, everybody. If there is leakage, we want to close the leakage. There is a pipe which is bleeding. We will do photocoagulation. If VEGF is getting secreted, just like in ARMD, everybody causing choroidal neovascularization. Here there is neovascularization of the retina. The drug will be anti-VEGF. So based on the pathogenesis, if we understand, we already know the treatment options, and that is what we will use all throughout these vascular disorders. Right, guys? I hope we are clear about the biochemical and the anatomical changes. If yes, let us move on to the clinical features. Let us start by reading the classification of diabetic retinopathy. The name of the classification is EEDRS. The full form is Early Treatment Diabetic Retinopathy Study. That's the full form, guys. Early Treatment Diabetic Retinopathy Study. ETDRS has divided diabetic retinopathy into two stages. Number one, NPDR. Secondly, PDR. NP means non-proliferative diabetic retinopathy, obviously, and P for proliferative diabetic retinopathy. Okay, everybody, no confusion. Now, if I want you to understand these two stages, I will ask you to focus on English. Proliferation, that's the only word which differentiates these two stages. Proliferation is a thing. What do you mean by proliferation? Proliferation means something new growing. What new is growing here, everybody? We have just now read the pathogenesis of neovascularization. What are we trying to say through the nomenclature? If there is neovascularization, it becomes PDR. If there is no neovascularization, means no proliferation, it becomes non-proliferative NPDR. That means there is one word which differentiates both these diseases, neovascularization. That means as a clinician, my job is as simple as finding neovessels. If I'm able to find neovessels, I classify as PDR. If I can't find any neovessels on the fundas, when I'm doing my ophthalmoscopies, I classify it as NPDR. Yes? So let us first of all see the sign of PDR. You already understand what is the sign of PDR, yes or no? The sign of PDR is neovascularization. Okay, this can be of two types, NVD, NVE. What is NV? NV is neovascularization. D for this, E for elsewhere. So we are saying neovascularization can either occur at the disc or elsewhere. How do we define NVD? Neovascularization at the disc or within one disc diameter. Either at the disc or within one disc diameter. Elsewhere, anywhere else in the retina, near the macula, near pure cerebellum, in the periphery, NVE. Okay, we know the sign. But how do we identify this sign? On examination. What will I see on examination? Understandable. How do we differentiate between a normal vessel and a neo vessel? A normal vessel is supposed to be straight and branching pattern like this. This is a normal vessel. But a neo vessel does not appear like this. Neo vessel appears something like this. We say on examination, there is a tortuous tuft of vessel. Again, pathology. We have read this. Now, we have seen a tortuous tuft of vessel. But because this is a vascular disorder, we can do which investigation, everybody? FFA. Yes. So on FFA, how will this appear? As I explained FFA to you, everybody, wherever there is blood, there is fluorescein dye. So now in this tuft of vessels, there is a lot of blood. So a lot of dye will collect. So will they be shining more or shining less? Meaning what? Meaning on a FFA image, there can be two types of lesions, either a hyperfluorescent lesion or a hypofluorescent lesion. Hyperfluorescent means which is shining, yes, white colored shining. Because there is some blood, as I showed you, leakage spots, everybody, yes. Because there are leakage of blood occurring there, the blood is accumulated, the dye is accumulated, pooling or leakage, everybody, that is why that area will shine. Similarly, I can say these are leaky vessels, everybody, these are tortuous vessels, a lot of dye will accumulate. So on FFA, these areas will be hyperfluorescent. Am I making myself very clear here? Wherever there is blood, there is dye. Wherever there is dye, they are hyperfluorescent. Okay, everybody. What will be hyperfluorescent? You will see in the mind. Okay. That is about our PDR. Newest question: how will we see on examination and what will be FFA? Do we need to see photograph for this? Yes, we will. Let us see. Let's see this photograph. This white big circle is made already to help you. If it doesn't help you, let me see the anatomy. This is my optic disc. From the optic disc, you see normal vessels straight and branching going out. Yes or no? Everybody straight and branching. You can see all these vessels. But if I focus on this tuft of vessel number 1, tuft of vessel number 2, everybody, can I see that this is a tuft? Can I see that this is a tuft of vessel? Making your life very easy. Making it a case of neovascularization at this NVD. Okay, I just rub the marking for you, everybody, so that you can see these images again. As soon as I see this, am I able to see on that is neo vessels, a tuft of vessels, everybody? Again, everybody see this here. Yes, sir. And that is how easy it is. But that is how easy it is in this image. Let us see another image, everybody. An FFA image. So everybody, as you can see, this is a fundus fluorescein angiography image. In this image, my only question to you is whether it is a case of PDR or NPDR. Whether you can see any neovascularization, yes or no, that's all. Let us try to find a hyperfluorescent, a white dish area which has some tuft. Can we find anywhere? Let me divide this photo into 4 zones and ask you which zone is it in? 1, 2, 3, or 4. Can you find neovascularization in any zone? 1, 2, 3, or 4? I can. Let us carefully see this, everybody. I'm also seeing it carefully, everybody. It's not as clear as the other photo. It is not as big a neovascularization. Yes, some of you have been able to find in zone 2. If not, everybody see, focus here, focus at my circle. Everybody see carefully. This is my normal branching vessel going, everybody. But in this area, it forms small tufts like this, everybody. If I can say something like a finger or a fan, everybody. Yes, this is a small vessel going here. This is neovasculation. This is PDR. There are lots of other things visible. Yes, I know there are lots of other signs visible. But as I said, I am bothered about what, everybody? I am bothered about whether I can see some neovasculation or not. Right, it's done. Let's move back to our classification. We are done with PDR. So now let's move on to NPDR. In NPDR, we are not being able to see neovasculation, that we know. But what are the other signs? So let us say A. What is the earliest sign? What is the earliest sign here, everybody? The earliest sign, yes, is microaneurysms. Microaneurysms. Now, what are the aneurysms? We already know everybody. Aneurysms are outpouching. Yes. So on examination, how will it be visible to you? Let me draw a diagram and explain. Let's say this is a blood vessel, which was red in color. Now there is an outpouching, which is also filled with blood. So what will I see? Along the blood vessel, I will see a red dot, or I will see multiple red dots. Yes or no? And these will be microaneurysms. So small red dots. So can I say on examination, tiny small red dots? On FFA. On FFA again, everybody, the dye is there in the whole blood vessel, and then the dye is going into these outpouches also. So what will I be able to see? Tiny hyperfluorescent dots. Yes or no, guys? Yes. Tiny hyperfluorescent. Very easy, simple. Now, also, what they can ask you, or what they do ask you is, which layer are these abnormalities seen in? So microaneurysms are seen in inner nuclear layer. Inner nuclear layer. Okay, now let us see a photograph of the microaneurysm. Same photograph, FFA photograph, in which we saw neovessels. These were your neovessels. Can you see some microaneurysms? Everybody see here, down here, microaneurysms. There is a blood vessel around that, there are small dots. See in all this area, everybody, all these are microaneurysms. Small dot-like lesions, here also, everywhere you will see numerous microaneurysms. I hope we are clear about this, no confusion. Now, another important sign B I can say, of NPDR is hemorrhage. Self-explanatory, everybody, leakage is occurring, so hemorrhage of blood is occurring. This hemorrhage can be of two types. One is flame-shaped hemorrhage, and the other is called as dot and blot hemorrhage. Okay, flame-shaped because it is long and thin. This is found in which layer? Superficial nerve fiber layer. Dot and blot is deep. It is found in outer plexiform layer. I don't think I have to explain you on examination. You will see a red-colored collection. Yes or no? No. On FFA, that's all I can ask you probably. On FFA, I've beaten around the bush so much, everybody. This is hemorrhage, blood will collect, fluid will collect, the dye will pool here. So they will be hyperfluorescent. Yes, sir, we know. I know you know. Hyperfluorescent. Then everybody, moving on to the next sign. Exudates. What are exudates? Exudates are lipid deposits. In which layer? Outer plexiform layer. Lipid deposits in outer plexiform layer. Now we are talking something apart from blood here. Yes? So if I ask you on examination, how do they appear? As soon as I think lipid, I think of oil. Yes or no? Oil is what colored, everybody? You must have poured oil in your homes, everybody. Sometimes while cooking, sometimes it is yellowish color. Yes? So that's what I say. Yellowish, irregular deposits. Yellowish, irregularly shaped deposits. What about FFA? Very simple concept. I hope you understand. Let's say this is my blood vessel. Over this blood vessel, I have an exudate. Okay. Now, everybody, when I do FFA, the dye will be here, the dye will be visible here. But at this spot, everybody, there will be no dye visible because it is hiding the dye. So this will appear as a dark area. So can I say on FFA, this will be a hypofluorescent area? Yes or no? I hope you understand because this is hiding the fluorescence. Yes? Let us see an image, again, the same image. In this same image, everybody, if I redraw this circle, this was my neovasculation. And if I show you this, see this green circle carefully. See this blue arrow carefully. What do I see? I see a small hypofluorescent area. Yes or no? Here again, I see some hypofluorescent small areas. That means this must be, maybe this is a case of exudate. Yes or no? Query exudate. I hope you are clear about this. How do hypofluorescent areas look like? Please remember, this is not hypofluorescent. This is your macula. This is not hypofluorescent. This is macula. Okay? Now, moving back a bit. Next sign. Cotton wool spots. Cotton wool spots are sometimes also called as soft exudates. Though this is kind of a misnomer. Because as soon as you hear exudates, you think about lipid deposits. But they're actually not lipid deposits. They are collections of neuronal debris. In which layer? Nerve fiber. Collections of neuronal debris in nerve fiber layer. See, anyways, our neurons are dying, but every tissue is dying, yes or no? But macrophages will clear the dead tissue. But here, because there is retinopathy, the amount of neurons getting damaged are much higher than the amount of clearance by macrophages. So this neuronal debris is accumulating in the nerve fiber layer, everybody, and we're able to see that. How are we able to see that? So on examination, yellowish, large deposits. Okay, large yellowish deposits. And they have regular, smooth edges. Like a bundle of cotton, yes or no? You take out cotton, there is a bundle of cotton, it is large, it is light in color, and it is almost circular or regular edges. Okay? Now, let us see some images. Let us see this image. In this image, what sign can you see? What sign can you see? Optic disc, okay, blah, 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 okay. What are these yellowish deposits? Irregularly shaped exudates. Let us see this image. What can we see? We can see a lot of scattered hemorrhages. Yes or no? All these are hemorrhages. Along with hemorrhages, we can again see what everybody saw. Exudates. Are we clear? No confusion. Let us see another image. In this image, what do we see, everybody? We see in these black circles a larger area of a smoother edge, yellowish color, and that is why they are cotton wool spots. And these two circles are showing you hemorrhages. What is also visible but not marked is neovascularization, if we see carefully. This is an area of neovascularization, right? That is how we look at a photograph and we are able to see all the signs. Moving back. Next sign is venous bleeding and looping. Or I can say venous tortuosity. Due to ensuing hypoxia, continuing hypoxia of the body, there is venous tortuosity, which presents as either bleeding or looping. Bleeding means dilated, constricted, dilated, constricted, dilated, constricted. Okay? Looping means the vessel will go like this, will loop over itself, and will become straight again. Okay? So these are venous tortuosities due to hypoxia. Pathology, basic pathology. Last important sign of a case of NPDR, that is non-proliferative diabetic retinopathy, is known as IRMA. What is IRMA? IRMA is intraretinal microvascular abnormalities. Intraretinal microvascular abnormalities. What are we trying to say? We are trying to say, let's say, this is my optic disc. These are my blood vessels. Let's say there is some leakage occurring from this blood vessel. Okay, leakage. Due to that, the area in front of this will become hypoxic. So the other blood vessel will form a small shunt vessel to this area. Okay, everybody? And this is intraretinal mites will become hypoxic. So the other blood vessel will form a small shunt vessel to this area. Okay, everybody? And this is intraretinal microvascular abnormalities. These are not neovessels, these are precursors to neovessels. Okay, everybody? So shunt vessels bypassing the capillary bed. If we see IRMA, we are almost always sure that this is going to become PDR in a little while. Yes? So IRMA is a dangerous sign in NPDR and it is a precursor for PDR. I hope we are clear about the signs, everybody, of a case of NPDR. Earlier sign with microaneurysms, then hemorrhages, then two signs which will cause hypofluorescent areas, exudates and cotton wool spots, then venous bleeding and IRMA. I hope we are clear about this, everybody. Two stages NPDR and PDR. Again, I will say NP means non-proliferative, no proliferation, no neovascularization. Proliferative means vascularization. The question comes into our mind, why have I divided it into two stages? What was the need of dividing it into two stages? I must have divided the two stages because of some difference in the treatment that I need to do in these two stages. Yes? So what are my treatment options? I will go back to pathogenesis. I have to stop the leakage, I have to stop VEGF. So I have to do photocoagulation, I have to give anti-VEGF drugs. But what do I do in NPDR, what do I do in PDR? So let's say there are three options, everybody. Number one, photocoagulation. Number two, anti-VEGF. And number three, obviously glycemic control. Out of these three options, which ones are you going to do in NPDR? No? So I will say, remember it very easily in another way. NP means non-proliferative, or I can say NP means no problem. P means proliferative, P means problem. So all I'm trying to make you learn here is NP is not good enough for me to institute any treatment. In NP, non-proliferative, no problem. All I do is ask the patient to have a better glycemic control and follow up. Okay? We know if the blood sugar levels are controlled, all this will stop, all this will get reversed, everybody. And we ask the patient to keep on following with us to be able to determine the progression or regression. Now, follow-up should be done in how many months? Depends on the stage, everybody. So NPDR can be divided into four stages: mild, moderate, severe, and very severe. Mild, moderate, severe, and very severe. Mild, we ask the patient to follow up in 9 to 12 months. Moderate, we ask the patient to follow up in 6 months. Severe, 4 months. Very severe, 2 months. Okay, everybody? So the follow-up time depends upon the stage of presentation. Now, what is severe and very severe NPDR? How do we diagnose whether it is severe NPDR or very severe NPDR? So, severe and very severe are based on a rule 4-2-1 rule. What is 4-2-1 rule? 4 quadrants of hemorrhage, 2 quadrants of venous bleeding, and 1 quadrant of IRMA. Okay? So, what we are saying is just like I divided a fundus picture into 4 quadrants, if all 4 quadrants have hemorrhage, or if any 2 quadrants have venous bleeding, or if any 1 quadrant have IRMA, these are the 3 conditions 4-2-1. Out of these 3 conditions, any one is C, then we have severe NPDR. But out of these 3, any 3 are C, then we have very severe NPDR. Are you clear about this? Yes or no? So based on our classification of non-proliferative diabetic retinopathy, all we need to do is ask the patient to follow up and have a strict control over his blood sugar levels. That everybody? Now let's say we had seen neovascularization. That means the patient was a case of PDR. So now we had 2 treatment options. What are the 2 treatment options we had? Photocoagulation and antibiotic drugs. So let's say again. That everybody? Now let's say we had seen neovascularization. That means the patient was a case of PDR. So now we had 2 treatment options. What are the 2 treatment options we had? Photocoagulation and antibiotic drugs. So let's say again. But no, it is not that simple. When I write A, I want to ask you, out of the 2 treatment options we have, what is the treatment of choice? Would you rather do anti-VEGF drugs or would you rather do photocoagulation? Think about it. Think about the pathogenesis, you will understand yourself. What would you rather do? See everybody, if I give anti-VEGF drugs, VEGF will decrease. Okay. But leakage is happening, leakage will keep on increasing, hypoxia will keep on increasing, and some time will come when your anti-VEGF action will become lesser than the VEGF getting secreted. So at last, we need to treat the base pathology. We need to be able to treat the leakage. That means we will do photocoagulation. Again, you're writing photocoagulation. But my question, where am I going to do photocoagulation? Obviously, it's a retina, we talk about retinopathy, but where in retina? Are we talking about photocoagulation at the oris retina? Are we talking about photocoagulation at the macula? Are we talking about photocoagulation at the optic nerve? Where should we photocoagulate? Where should we photocoagulate? Think about it. Think about it. Think about the fact that we know PDR can present either as NVD or as NVE. NVE means elsewhere, elsewhere means I know this neovascularization can affect any part of my retina. So should I photocoagulate my whole retina? Yes. That is the treatment of choice. Pan retinal photo. Photocoagulation. PRP. Pan retinal photocoagulation. Now we should already know through our various readings that for photocoagulation, the laser that we use everybody is argon green laser. Okay, everybody? I hope you know this. Please remember some simple points. Pan retinal photocoagulation is done in multiple sittings. It is never use everybody is argon green laser. Okay, everybody? I hope you know this. Please remember some simple points. Pan retinal photocoagulation is done in multiple sittings. It is never done in a single sitting, everybody. And the most common side effect is visual field defects. Doing photocoagulation is like playing a video game. So basically, there are lots of video games in which you have a gun in your hand and you have to shoot everybody. Yes or no? cardiovascular disease, coexisting cardiovascular disease.
Hi,
Some
enjoy
kind of
study.
bypass has been done. The patient is on stent. The patient has a pacemaker, something like that. Yes or no? So in these three cases, we prefer giving intravitreal. Patient has ischemia has developed in a pseudo-phakic patient, or if patient has cardiovascular disease, coexisting cardiovascular disease. Some kind of bypass has been done. The patient is on stent. The patient has a pacemaker, something like that. Yes or no? So in these three cases, we prefer giving intravitreal triamcinolone. What will be our third option? What will be our third option, everybody? Leakage is occurring. Leakage must be leading to release of VEGF. Yes. So our third option is anti-VEGF drugs. Anti-VEGF drugs are preferred if center involving edema. Center involving edema means within 300 microns of center of macula with foveal thickness. See, as soon as I say center involving edema, we are talking about fovea. The center of macula is fovea. Yes. So we are essentially now here saying that we don't have macular edema. We have only foveal edema. So foveal thickness greater than 250 microns. Now the question is, if there is foveal edema, why am I not preferring the treatment of choice? Why am I preferring anti-VEGF drugs? See, answer I just now gave. The most common side effect of photocoagulation is visual field effects. If I photocoagulate the fovea and by mistake I photocoagulate wrongly, I will lose which vision, everybody? I will lose central vision. I don't want to take a risk with my central vision, everybody. So whenever you are having some doubt, say no to photocoagulation, say yes to anti-VEGF drugs. I hope you understand this. Okay. The treatment for macular edema again is not done in all cases. Treatment is done only if CSME. Okay. CSME is clinically significant macular edema. Treatment is done only if CSME, clinically significant macular edema. So what is clinically significant macular edema? Retinal thickening due to edema, thickness will increase within 500 microns of center of macula, or exudates
Bihar, bro.
within 500 micron of center of macula. But if retinal thickening, I'm writing RT, present anywhere. I hope you understand what I'm saying. CSME, I'm saying if retinal thickness is present within 500 micron of center of macula. Okay, so that means towards the center, then we are treating. Number one. Or number two, we are saying if exudates are present within 500 micron, but there should be some retinal thickening present, whether it is present within 500, outside 500 matter does not. Okay. Number three, retinal thickening or exudates greater than 1 disc diameter in size within 1 disc diameter of center of macula. In point 3, we are saying either you have retinal thickening or you have exudates. We have increased the area. We have increased the area to within 1 disc diameter. Within 1 disc diameter means within 1500 micron. I hope you remember 1 disc diameter is 1.5 mm, which is 1500 micron. But then, if you have increased the distance, everybody, then the size of the lesion itself becomes important. So retinal thickening itself should be 1 disc diameter, or exudate should be covering an area of 1 disc diameter. I hope you are clear about this. That is our first complication, everybody. Macular outside 500 meter does not. Okay. Number 3, retinal thickening or exudates greater than 1 disc diameter in size within 1 disc diameter of center of macula. In point 3, we are saying either you have retinal thickening or you have exudates. We have increased the area. We have increased the area to within 1 disc diameter. Within 1 disc diameter means within 1500 micron. I hope you remember 1 disc diameter is 1.5 mm, which is 1500 micron. But then, if you have increased the distance, everybody, then the size of the lesion itself becomes important. So retinal thickening itself should be 1 disc diameter, or exudate should be covering an area of 1 disc diameter. I hope you are clear about this. That is our first complication, everybody, macular edema. Now, second complication. The second important complication of diabetic retinopathy is vitreous hemorrhage. Vitreous hemorrhage. Now, as soon as I say the word hemorrhage, everybody, the first question I always want to ask is, what is the source of my hemorrhage? Where is the blood coming from? Is vitreous vascular or avascular? We all know vitreous is avascular. There is nothing called vitreal blood vessel. So that means where is the blood coming from? Simple thing. This is my retina. This is my vitreous. Posteriorly, vitreous touches the retina. Anteriorly, vitreous touches the lens. Lens is also avascular. So the only vascular structure in contact with vitreous is retina. That means the bleeding must be occurring from retina. Yes. So canine touches the retina. We all know vitreous is avascular. There is nothing called vitreous. Now, as soon as I say the word hemorrhage, everybody, the first question I always want to ask is, what is the source of my hemorrhage? Where is the blood coming from? Is vitreous vascular or avascular? We all know vitreous is avascular. There is nothing called vitreal blood vessel.
हाँ
That
आरिफ
means where is blood
बोलो।
coming from? Simple thing. This is my retina. This
बिहार
is my
से हूँ भाई।
vitreous. Posteriorly, vitreous touches the retina. Anteriorly, vitreous touches the lens. Lens is also avascular. So the only vascular structure in contact with vitreous is retina. That vitreous hemorrhage. Vitreous hemorrhage. Now, as soon as I say the word hemorrhage, everybody, the first question I always want to ask is, what is the source of my hemorrhage? Where is the blood coming from? Is vitreous vascular or avascular? We all know vitreous is avascular.
ए ट्रिप द ब्लॉग भैया मैं बहुत कंफ्यूज हूँ। मैं सीयूईटी दूँ या नीट में? अभी 12th में हूँ, प्लीज़ बता दीजिए। दोनों दो। सिलेबस तो दोनों का सेम ही है। सीयूईटी में 12th पूछा जाता है ना। दोनों दो, क्या प्रॉब्लम है?
Hypertensive retinopathy occurs due to hypertension, no brainer. Hypertension, what does it do, everybody? It does, number one, vasoconstriction. Yes? So there is a vasoconstrictive phase, first of all. Blood vessels constrict. After that, there is what, everybody? Atherosclerosis. So there is sclerotic phase. Focus on the word So there is a vasoconstrictive phase, first of all. Blood vessels constrict. After that, there is what, everybody? Atherosclerosis. So there is sclerotic phase. Focus on the word atherosclerosis. See, this is not specific to the eye, everybody. This is everywhere in the body. Hypertension is a systemic phenomenon. Atherosclerosis means deposition of a plaque in the lumen of the artery, which leads to narrowing of the artery. Yes, narrowing will lead to less blood flow forward. Less blood means less oxygen. Less oxygen means hypoxia. Hypoxia leads to release of VEGF. VEGF leads to neovascularization. Same fundamental is. And due to the atherosclerosis, there will be exudation from the blood vessels. So we are calling it exudative phase. So this is how hypertension proceeds everywhere in the body. Yes, based on this, everybody, and based on the similar pathogenesis as diabetes, we can study the clinical features. Clinical features are discussed under a classification which is popularly Keith Wagner classification. Even as third year MBBS students, guys, I hope we have encountered this name. This is a very common question to be asked in third year in Vivas as well as in theories. Keith Wagner says that the findings in hypertensive retinopathy can be divided into 4 grades. Grade 1. In grade 1, what is being seen? The vasoconstrictive phase. Vasoconstrictive phase means due to hypertension as a response, all the blood vessels are getting constricted. So what you end up seeing is arteriolar attenuation. Arterioles, which are small vessels with narrow lumen, they are getting constricted, so they are almost getting closed. Closed means attenuated. We say that the normal AV ratio in terms of diameter is equal to 2:3. Arteries have narrower lumen than veins. But in hypertensive retinopathy, this AV ratio diameter decreases to 1:. Okay, that's the way we recognize a vasoconstrictive phase. That's the earliest finding in hypertensive retinopathy also. In grade 2, now atherosclerosis has started to occur. Due to that, you see a named sign. What is that sign known as? Sallu's sign. Instead of Sallu's sign, I call it Sallu's sign to be able to remember it. If you know Salman Khan, everybody, Salman Khan in the Bollywood industry is popularly known as Sallu Bhaiya. So remember Salman Khan sign or Sallu's. Yes. Now grade 3. Grade 3, the atherosclerosis is continuing, giving rise to 2 other signs, which also Salman Khan helps us remember. Sallu sign, Salman Khan. Salman Khan ने गाड़ी के bonnet पे bonnet sign गन रखा, गन sign. Okay, everybody. सलमान खान ने गाड़ी के bonnet पे रखा गन. सलमान खान These are the four grades. Please remember them.
नहीं, bio नहीं है.
Constriction, sclerosis, and exudation. As simple as that. If I show you a photograph now, everybody, focus on that photograph at the top. What are you able to see? Let's see. First of all, let's see the white arrow. At the white arrow, what do you see? You see a hemorrhage. Yes or no? You see a hemorrhage. What shape of an hemorrhage? Flame-shaped hemorrhage. So the white arrow is the flame-shaped hemorrhage. Now let's see the black arrow, everybody. At the black arrow, we are able to see a pale yellow large collection which looks like a cotton. Yes or no? So this is a cotton wool spot. We know this. But flame-shaped hemorrhages and cotton wool spots can also be seen in diabetes. Why? It is a case of hypertensive retinopathy. For that, look at the box. In the box, what do we see, everybody? We see that the artery is going, and below that, if we see, we are able to see the deflection of the vein. If you carefully note the vein, everybody, the vein is coming, then dipping down, and then coming back up again. Yes, I just clear it for you, everybody. Now that you know it, probably you will be able to notice this. This is the subtle change that we need to notice, everybody. The artery going, vein dipping in, coming out. Arteriovenous change. I don't expect you to answer whether it is Salus bonnets or guns, but at least you should be able to answer that it is an AV change. So along with cotton wool spot, flame-shaped hemorrhage, AV change makes it grade 3 hypertensive retinopathy. Am I crystal clear? Yes. Let's see another photograph.
नजर लग
In
जाएगी.
this photograph,
क्यों
what do we see,
भाई?
everybody? At the blue arrow, we see a cotton wool spot.
किसको नजर लग
Cotton wool
जाएगी?
spot. This again, we see a cotton wool spot. Yes. Now focus on the optic disc. Are you able to see any margin of the optic disc at all, everybody? No. So there is swelling of optic disc. Yes. Papilledema. Also, if you look at the macula, we see exudates. In what kind of an appearance, everybody? Macular star appearance. Yes, you've already read the causes of macular star, everybody. I hope you will go back to it. You will be able to remember this macular star appearance. We have read it in neuro-ophthalmology. Macular star is seen in cases of neuroretinitis also. There we have listed hypertension also as a cause. But which hypertension, everybody? It is specifically a case of malignant hypertension. Macular star exudation is seen in malignant hypertension. Malignant hypertension along with swelling of optic disc makes it grade 4 hypertensive retina. Am I clear? Malignant hypertension can only occur in grade 4 after everything is crossed due to severe rise of hypertension. Am I clear to everybody? So you can even tell the grade of hypertensive retinopathy if you apply your mind to it. Again, you have to just see the anatomy. What is happening in the optic disc? What is happening in the macula? You have to see the.
अकेले में करते तो फिर थोड़ी देर में उठ जाते हैं, बट कैमरा ऑन करके करना पड़ रहा है तो थोड़ा पढ़ना ज़्यादा पड़ रहा है, इसलिए. ठीक है.
Vessels and all the lesions. Right, guys? That's as simple as
आप
hypertensive
पढ़
retinopathy.
क्या रहे हैं?
Steve Wagner Barker.
Ophthalmology.
Bonnets, guns, copper wire, silver wire. That's it about hypertensive retinopathy. Nothing more. Done. Let's check the next pathology now, everybody. Vascular group of disorders, central retinal artery occlusion, or popularly short form CRAO. I don't think I need to go into the pathogenesis. Retina artery getting obstructed, no blood flow, hypoxia, VEGF neurostimulation. Yes, I will straight away jump to what are the causes. Why is the central retinal artery getting obstructed? Number one, the most common cause, everybody, is atherosclerosis. Just like in hypertension, if there is complete occlusion or partial occlusion of the central retinal artery due to atherosclerosis, we will call it CRA. Secondly, apart from this atherosclerosis, what other phenomena can lead to any artery occlusion? Yes, all of us know that. A thrombi, when it breaks, is known as emboli. Emboli can transfer anywhere. Yes, so emboli. There is a specific type of emboli, guys, that we should be aware of as far as the name is concerned. This is known as Hollenhorst plaque. Hollenhorst plaque is a cholesterol emboli, which originates from bifurcation of common carotid artery. Okay, let's start. From bifurcation of common carotid artery, I hope after that you understand. From common carotid artery, internal carotid artery, from that into the ophthalmic artery, and the branch of ophthalmic artery is central retinal artery. So from here it will travel up to here. Am I clear to everybody? So if you know the blood supply, if you know the branches, everybody, as we already discussed various times now, from common carotid artery, internal carotid artery, from that into the artery, and the branch of ophthalmic artery is central retinal artery. So from here it will travel up to here.
मैंने फिजिक्स पढ़ लिया, अब आप पढ़ो।
Am I clear to everybody? So if you know the blood supply, if you know the branches, everybody, as we've already discussed various times now, we should be able to understand. So please remember the name Holland horse plaques that is used as part of MCQs. The third important cause is giant cell arteritis.
तो जेई एस्पिरेंट हो तो क्या हो गया, फिजिक्स तो पढ़ना पड़ेगा ना, पढ़ो फिजिक्स।
Yes, a large vessel inflammation, vasculitis, everybody affects the temporal artery, giant cell arteries. Yes, these are the three common causes. There can be thousands of other causes. I hope you understand anything which can obstruct a vessel, which can form a thrombi. So if I say what is the most common side effect of oral contraceptive pills, we know thromboembolic episode. So that can also lead to CRA. So similarly, we have to think about it. Any coagulative disorder, all of those can lead to CRA. But these are the three most common presentations. Right now, after we know the common causes, we need to know the clinical features. Number one, when the artery gets obstructed, obviously absolute hypoxia will ensue. So there will be loss of vision. But the loss of vision will obviously be sudden and it will be dangerous. Please remember here.
अरे मैं क्यों पढ़ूं फिजिक्स, मुझे जब पढ़ना था मैंने पढ़ चुका हूँ, ठीक है। अब फिजिक्स क्यों पढ़े, पागल थोड़ी है। फिजिक्स को नमस्कार दूर से ही।
Talking about an emboli or an atherosclerotic, you're not talking about an inflammatory event, so it will be painless. And it causes, there can be thousands of other causes. I hope you understand anything which can obstruct a vessel, which can form a thrombi. So if I say what is the most common side effect of oral contraceptive pills, we know thromboembolic episode. So that can also lead to CRA. So similarly, we have to think about it. Any coagulative disorder, all of those can lead to CRA, but these are the three most common presentations. Right now, after we know the common causes, we need to know the clinical features. Number one, when the artery gets obstructed, obviously absolute hypoxia will ensue. So there will be loss of vision. But the loss of vision will obviously be sudden and it will be painless. Please remember, we are talking about an emboli or an atherosclerotic event.
क्या बोल रही है जानवी, आप पढ़ो फिजिक्स में, आप डिस्टर्ब हो जाओगे मेरी बात तो नहीं।
We are not talking about an inflammatory event, so it will be painless and it will be sudden. As soon as the artery gets obstructed, there will be no blood, there will be hypoxia, and it will lead to sudden vision. That is what usually the patient will complain of. Secondly, because this is a retinal disease, this retinal disease can lead to optic atrophy. As we already know, all retinal diseases can lead to optic atrophy, which is consecutive. Thirdly, we again know that because the retina will lose its blood supply, the nerve fibers will lose their nerve supply. The optic nerve will also get affected partially, leading to the classic RAPD or Marcus Gunn. This has already been understood in neuro-ophthalmology that partial diseases of optic nerve or diseases of retina like CRA or retinal detachment, everything can lead to RAPD or Marcus Gunn tumor. Fourth element, fundus appearance. When you look at the fundus, what will you be able to see? Number one, because the fundus is losing its blood supply every yes, what is ensuing everybody? Exudation. All the blood vessels are now undergoing the dilatation. Yes, so there is edema. Edema is leading to a pale fundus. When there is no blood coming, everybody, as a response, the blood vessels start to dilate, leading to retinal edema, leakage of fluid, and due to that edema, everybody, you can't see the red color coming from the choroid, and the fundus becomes pale. Are you able to understand this? Retina is transparent, that is why the fundus appears red in color due to the choroid color. But when the retina will become edematous, edematous means hazy, it will hide the red color of the choroid coming from here. Secondly, we say cattle tracking fundus due to segmentation of blood column. Very easy again to understand everybody. Let's say this is my artery. This is where it has been blocked. So posterior to the block, distal to the block. Now the blood is not
मैथ नहीं पसंद है।
but the artery is continuing its pumping action. So what do we see? We see when there is no blood coming, everybody, as a response, the blood vessels start to dilate, leading to retinal edema, leakage of fluid, and due to that edema, everybody, you can't see the red color coming from the choroid, and the fundus becomes pale. Are you able to understand this? Retina is transparent, that is why the fundus appears red in color due to the choroid color. But when the retina will become edematous, edematous means hazy, it will hide the red color of the choroid coming from behind. Secondly, we say cattle tracking fundus due to segmentation of blood. Very easy again to understand everything. Let's say this is my artery. This is where it has been blocked. So posterior to the block, distal to the block. Now the blood is not flowing anymore, but the artery is continuing its pumping action. So what do we see? We see that there is a little bit of blood. then the blood vessel is empty because the blood has been pumped out, then there is blood again an empty blood vessel, then again there is presence of blood. So it looks as if kettle has walked over my artery. So wherever kettle has kept the foot, the blood has vanished, then there is blood, then blood has vanished, then there is blood. So segmentation of blood column due to no blood flowing and the contractile action of the artery. Am I clear to everybody? So known as cattle tracking fundus. After this, the characteristic thing that we all are aware of, I hope,
cherry red spot.
spot at macula. Cherry red spot at macula. Yes or no? It's a classic finding. Now the question comes, why does cherry red spot occurs? Why does cherry red spot occur at the macula? I've seen a lot of students answering because macula has a dual blood supply. That is an absolutely wrong answer. Cherry red spot occurs at macula due to collection of fluid in ganglion cell layer of retina. Now this ganglion cell layer, everybody, as we already know, or I think we should know, is absent at fovea. So basically what is happening? If we try to understand, the whole retina is edematous. I can say hazy. Yes. If the whole retina is edematous or hazy, what we are able to see, pale fundus, as choroid red color is not visible due to retinal haze. Okay. But fovea remains transparent. As ganglion cell is absent at fovea, so there is no edema. So fovea remains transparent. Because fovea remains transparent, everybody, that is why I can say the choroidal red color is visible at fovea. And this red color that is actually visible at fovea gets the name cherry red spot. If you try to understand, everybody, 99% of the retina is opaque, so red color is not visible in 99% of the retina. But the red color is only visible in the center of the macula, center of the fovea, that is fovea, and that is why that appears red. So the red color of the cherry red spot is actually the normal part of the retina. The rest of the retina is pale. The rest of the retina, everybody, is the part which is happy. If we see a photograph now, everybody, let's see this photograph. What do we see, everybody? Look at the macula. Everything is pale in the macula. Only the center of the macula. Cherry red spot at macula. Surrounding this, everybody, all this is now pale red. Am I crystal clear, everybody? So the simple fundamental of why my fundus appears red, the same fundamental, retina remains transparent, it will still appear red, but if the retina becomes hazy in the surrounding, it will become pale. So please take home message, cherry red spot is the normal piece of retina, surrounding that it is the abnormal. Am I crystal clear, everybody? No confusion about this? Done? Okay. Now, let me show you another photograph and ask you the diagnosis. Let's see this. What is your diagnosis? What is your diagnosis? Obviously, we are discussing CRA, so you will be tempted to say CRA. But is it CRA? Is it CRA? If you look at it carefully. When you are looking at this image, you are focusing on this part. I know you are focusing on this part. Why are you focusing on this part? This is also CRAO, guys. Why is it CRAO? What do we see everywhere? There is no red color. It is completely
बिहार से.
Only this part of the retina is normal. Am I crystal clear, everybody? So the simple fundamental of why my fundus appears red, the same fundamental, retina remains transparent, it will still appear red, but if the retina becomes hazy in the surrounding, it will become pale. So please take home message, cherry red spot is the normal piece of retina, surrounding that it is the abnormal. Am I crystal clear? No confusion about this? Okay. Now, let me show you another photograph and ask you the diagnosis. Let's see this. So I will say figure 2. What is your diagnosis? What is your diagnosis? Obviously, we are discussing CRA, so you will be tempted to say CRA. But is it CRA? Is it CRA? If you look at it carefully. When you are looking at this image, you are focusing on this part. I know you are focusing on this part. Why are you focusing on this part? This is also CRA, guys. Why is it CRA? What do we see everywhere? There is no red color, it is completely pale. Only this part of the retina is normal. Why, everybody? If you remember cilioretinal artery, in 75% of the cases, cilioretinal artery branch of posterior ciliary artery supplies the macula. So from the optic disc, everybody, the macula is still getting supplied. So these vessels are not affected. This part of the retina is not losing its transparency. And if you see at the macula, obviously dark brown color is seen. I know it's not absolutely a red color. So obviously it depends on the quality of the photograph. So this is a cherry red spot. Am I clear? So this is CRAO with cilioretinal artery spared. Okay. See the corresponding FFA, everybody. When I see the FFA, what do I see? That no blood vessels has filled with dye. Because there is central retinal artery occlusion, there is no blood in any of the blood vessels. So there is no dye, everybody. So no dye in any blood vessel. But we see the dye filling which? Dye filling cilioretinal artery. I hope I'm clear here. So this confirms that this is a case of CRAO, central retinal artery occlusion. Only the cilioretinal artery is supplying the macula. Am I clear to you? So there can be various presentations of the same case. I hope you are able to understand this. There should be no doubt. There should be no confusion. Done, everybody? Now, I move back to cherry red spot. We see that cherry red spot is occurring at the macula due to problem in the ganglion cell layer. Why does cherry red spot appear cherry red in color? We have explained it. But if we have read biochemistry, have we heard the name cherry red spot before today? Yes, we have. At lots of places, Niemann Pick test X. That means cherry red spot is not specific to. So, what is the differential diagnosis of cherry red spot at macula? This can be remembered to a mnemonic. It's a very old mnemonic. I just modified and made it a little better. Cherry trees never grow tall in
Bye.
sand, mud, and grind. So just extended the mnemonic. Causes of cherry red spot, the mnemonic starts with cherry. Very easy to remember. Cherry trees never grow tall in sand, mud, and grind. Do it with your teacher. Okay, let's see. C. C for what we are discussing. C, A, O. T. T for trauma. Please remember specifically blunt trauma. N for biochemistry now, everybody. Niemann-Pick's disease. G for gangliosidosis type 1. T for Tay-Sachs disease. Sand for yes, Sand-Hoff's disease. If you know biochemistry, Tay and Sand-Hoff's are types of gangliosidosis type 2. M for metachromatic leukodystrophy. The last G is the famous name, Gaucher's disease. Okay, so these are all the names. I will continue on the list. Cherry trees never grow tall in sand, mud, and grind. The first two are ocular causes. Rest all other causes everybody are biochemistry or storage systems. Okay? Yeah. Please remember, pediatrics books say, even Nelson's pediatrics textbook, both of them say that Gaucher's disease does not present with cherry red spot. I am telling you that Gaucher's disease presents with cherry red spot.
फाइनली 1 आवर पढ़ लिया। मिलते हैं किसी अगले लाइव में, तब तक के लिए बाय।